Assalamu alaikum wa rahmatullahi wa barakatuh. Ahlan wa sahlan, a warm welcome to Muslima Insight. Today in Muslima Insight, we are continuing our discussion on anxiety disorders, and in particular, we're going to look at obsessive compulsive disorders, also better known as OCDs. And with me in studio to share with us their knowledge on this topic, we've got the lovely Nazmira Kamisa. Doctor, a warm welcome and assalamu alaikum.
Wa alaikum salam, and thank you for having me, Adila.
And of course, we also have Fatima Umar, who is a clinical psychologist that has joined us today to also share with us her knowledge. Assalamu alaikum and welcome.
Wa alaikum salam wa rahmatullahi wa barakatuh. Thank you for having me.
In last week, just for the sake of our viewers that may have missed, anxiety disorders is obviously defined as an apprehension over an anticipated future event or threat. And we also, very quickly, I'll just go through what we have discussed. We looked at specific phobias, where a person has a fear of an object or a situation, and it is really out of proportion to any real threat that this object or the situation may pose. Then we also looked at social phobias, where a person has a fear of unfamiliar people that they don't know, or of social scrutiny. Then we also unpacked generalized anxiety disorder, and my viewers would remember that I unpack as most details as possible so that they really get and understand what each disorder really entails. General anxiety disorder, we know that it should be an uncontrollable worry for at least 6 months for a person to be able to, for a psychiatrist to say, you have generalized anxiety disorder. And then we also looked at panic disorders and post-traumatic stress disorder. Now, instead of me unpacking more and giving some examples, due to the spate of xenophobic attacks that we've witnessed and seen in the last week or so in South Africa, I would like to start off by recapping a little bit of acute stress disorder, that is, I think, within the first 4 weeks after a traumatic event, post-traumatic as well as panic disorders. Dr. Kamisa, can you share with us what can people that have been witnessed to a traumatic event where people were killed, people were maimed, people were set alight, what goes through the person that is witnessing that? What can they expect?
So if we're looking at in the potential risk in those individuals, it would be disorders like acute stress disorder, or going forward into the future, post-traumatic stress disorder. In the case of these disorders, both, the prerequisite is that that individual would have experienced a traumatic event like what you've described. Okay, so either witnessed or directly experienced an event where there was potential threat of harm or actual harm to the self, to the integrity of the body, people being murdered, killed, injured, or hurt or harmed in some way. And combined with this, it's not a prerequisite, but often that individual is then faced with intense fear, helplessness, and horror. Okay, so this is part of the definition. And then after that, that individual often develops either an acute stress disorder, so symptoms of dissociation, which means removal of the individual from their normal awareness. So a difficulty in experiencing that emotion in a, if we want to say a healthy way, they dissociate. So they almost separate themselves on an unconscious level. So this is not a conscious thing. Things like numbing, or depersonalization, which means feeling like you are out of your body. Derealization, so feelings like things around you are unreal, or the world is not real. You feel separated from things or disconnected from things. And then also feeling like you're in a daze. So people often describe symptoms like that in the initial phase of an acute stress disorder, combined with 3 groups of symptoms which you can get in the acute phase, as well as going forward into the post-traumatic phase, which would then imply that this goes on for longer than 6 months. So re-experiencing symptoms like having flashbacks of that event, having dreams, having vivid recollections of it, avoidance, so these people will then begin to avoid situations or people or places that remind them of it. And then hyperarousal. So hyperarousal symptoms refer to intense irritability, difficulty sleeping, an exaggerated startle response, which is a common thing, you know, like if somebody comes up behind you and you are startled and become very fearful and you're very sensitive. So those are the type of symptoms that you would expect. And this is in an individual who has a response where they develop pathology. So not everybody will get this. Certain individuals are just more prone to it. It also depends on the intensity of the trauma, their emotional reserve, whether they have other conditions, other anxiety disorders, whether they're already depressed, you know, whether the person that was involved in this potential, for example, the xenophobia, if you knew the person, if it was a family member, if you somehow related to that individual on whatever level. So all of these things would then determine whether somebody exposed to a traumatic event like that will develop an acute stress disorder or a post-traumatic stress disorder.
And what can individuals that were exposed, perhaps not so closely related to some of the victims, but just in the general sense of the crowd being present, what can they do to get alleviation from those symptoms? Because obviously, if we talk about panic attacks, it can be quite severe where the person will feel that they're dying because of the claustrophobia and the heart racing and the sweaty palms. What can they do to alleviate some of those symptoms?
So looking at the individual on their own, you know, we can start with certain strategies that they can use for themselves. So trying to calm yourself down, which isn't always possible. It's never easy. Okay, so breathing exercises is one, because we know, like we said before, that people stop breathing when they're anxious. So breathing, taking deep breaths, becoming conscious of your breath, trying to reassure yourself that this is just a panic attack, and telling yourself that, so that you remove yourself from that, like you said, that intense fear. One of the core things about panic attacks is that the person feels like they're about to die or about to go mad, or that something bad is about to happen. So cognitively, using thoughts that will then remind you that this is just a panic attack. I'm going to be okay and it will end. So that is one of the things which I think Sister Fatima will know a lot more than me about. And then we look at relaxation exercises, distraction techniques, you know, and then obviously medication. So, you know, if these things become disabling in the sense that they impact on your functioning, on your daily life, affecting your work or your home life or your social interaction, we need to look at medication. Okay, we know that psychotherapy is first line for anxiety disorders, and often in some cases, depending on the severity, we do need to use medicine, and then combination therapy becomes beneficial. But I think Sister will know more about me about that than I do.
Sister Fatima?
I think I absolutely agree with you in terms of, you know, having the combination of treatments that's very, very effective. You know, Sister Adela, mentioning the anxiety, the acute stress disorder in relation to the xenophobic attacks, I think is very relevant to what's going on. But I think we need to be aware that these attacks are ongoing. They're not going away. So often some of the avoiding specific areas or avoiding going out, part of it is relevant and appropriate. I mean, people would be afraid to just go out and there's a real threat that's out there. In terms of the treatment, you know, when someone has just experienced a traumatic event, to go in and discuss it over with them can be more traumatizing. So what you really want to do is to just help them feel secure, help them feel safe, and help them feel supported. And sometimes that's just trying to source out either family members or relatives or friends, somebody that can make them feel safe again. And then obviously you want to treat them medically. But after, so we're looking at around 2 to 3 weeks after the event has happened, that's when you can get psychological assistance in terms of therapy. Again, we'd look at more supportive therapy, trying to sort of stabilize them in their life again, help them to be functional again, going through the process of feeling safe.
And it's obviously not to probe and keep on poking at the person to say, talk about it, when that person is not ready. On that note, it is time for us to go to an ad break. Stay tuned. Assalamu alaikum wa rahmatullahi wa barakatuh. A warm welcome back to Muslima Insight. Sister Fatima, as you were explaining before the break, it is very important for the people that is in the ecology or in the surrounding area of the person that were traumatized, that they have some idea of how to support that particular individual. Are there any specific examples that you can give to those people in that person's ecology, what they can do immediately if they see this person is having an attack or they're becoming very anxious?
You know, I think, like I said earlier, it's about stabilizing and supporting. So obviously you're going to take them out of the traumatic environment. That would be the first step. If they've just witnessed something and you've been present or nearby, to take them out of it, to go to a place that they're familiar with, that they feel secure in, whether that's a home, a neighbor's house, a relative's house. And then to sort of just, you know, I would suggest simple things. Give them a cup of tea, let them sit down, help them to relax, reinstate the breathing. As Dr. Nazmira was speaking about earlier, we're trying to bring down the levels of anxiety instead of escalating them. So we almost want to just create an environment of calmness, stability, serenity, really.
And that safety zone, obviously, as well. And coming now to today's topic on OCDs, can you give us the definition of obsessive compulsive disorders?
Okay, so OCD is an anxiety disorder characterized by unwanted thoughts. So unwanted, repetitive thoughts that the individual will experience and attempt to resist. It is their own thoughts. Okay, so it is not thoughts that they feel have been inserted into their head. It is their own thoughts, yet they have no control over these thoughts. So they try to stop them, try to resist them, but it becomes very difficult and almost impossible to resist these thoughts, as well as sometimes, not in all cases, compulsions. So those are repetitive actions or rituals that people will then carry out in order to, usually in an attempt to decrease anxiety. And in most cases, or in many cases, the obsessions are related to the compulsions. So for example, an obsession about cleanliness would then potentially lead an individual to constantly wash their hands, and that would then be the compulsion. The key thing is that it becomes very time consuming, very repetitive, completely irrational. So the person will recognize this as an irrational thought, which leads to this irrational action, yet they have no control over it. And in cases where we have situations like that, for example, somebody would wash their hands until their skin would come off, or that they would develop dermatitis because of possibly using so much antibacterial soap on their hands. So there are often consequences. It takes a long time and it affects their functioning.
Absolutely. Fatima, in your practice, what have you experienced?
Okay, so in terms of your obsessive compulsive disorder, I mean, I think you find them a lot more in an acute hospital setting. They would obviously follow on then for therapy. I haven't found so much in my practice at the moment, but I think it is prevalent. It is out there. It's not as much as your other anxiety disorders, your generalized anxiety, your panic attacks. It's definitely not as prevalent as that. But I think, you know, OCD is a very debilitating anxiety disorder from the others. And I think it makes it so much more unbearable to live with. The thing that I find, people don't always ask for help, and that's because there's so much of shame associated with this type of a disorder. They don't necessarily want to just come out and say that there are these thoughts in their head, or that they're carrying out these activities. And I think because of the shame, and that it doesn't feel almost, you know, what we refer to as egocentric, so it doesn't feel like it's appropriate with the way your being is, and that's what makes it so difficult to reach out for help.
So again, the stigmatization that we need to address and say to people, it's okay to reach out for help. Because there is help. And then coming also to, is there any ratio that one can put down to gender? Is it more prevalent among women or men? Because normally, like we're speaking about stigmatization, women being more emotional, a lot of people automatically think women will suffer with this more. And I think we need to hear the truth today.
Anxiety disorders in general are more prevalent in females, with the exception of OCD. So OCD is equally present and prevalent in males and females, interestingly enough. And then we don't see any difference in between cultures. It happens in all cultures, in all religions. It happens in Muslim people, because I've often been asked this question by patients who have obsessive thoughts. And obsessions are specifically something that we call pure O, which is, it's referred to colloquially as pure O. So obsessions in an isolated disorder, so without the compulsions, are often very resistant to treatment. So individuals having thoughts of a religious nature, potentially, or thoughts that they would feel are dirty thoughts, of possibly about intimate relations, are often difficult for those individuals to live with, because they feel that there must be something wrong with them, and that it is their fault. And like Sister Fatima said, there's shame that is attached to that, because they then take ownership of those thoughts and blame themselves, yet are faced with this difficulty because they are not conscious. They're trying to resist these thoughts, they're trying to stop these thoughts, yet they are taking on the blame and the shame related to them. So this can be a very disabling condition. It can be disabling in the sense of the amount of time that it's taking up. People can take hours to leave the house. They can be late for work. They can get home and spend 2 or 3 hours every day checking things, for example. So if you have an obsession about safety, or a checking obsession, checking that the doors are locked, checking that the stove is turned off, checking any number of things, counting rituals. So taking up time, but also then the emotional burden that it carries with it, with this blame and the shame that comes along with it.
Is there any particular reason why a person would become OCD? Is there genetics involved? Is it an event that might have happened that have triggered that? What exactly causes a person to become obsessive compulsive?
I don't think we know what the cause of OCD is. So there is no causal relationship, but we do know that genetically anxiety disorders are more prevalent in families. So we talked about before where with general other anxiety disorders, so a child of somebody with an anxiety disorder is 6 times more likely to develop one. So modeling is important in that, and so is genes. So them watching us as well as their genetic load. And then obviously drugs, medications, people who use alcohol, are more likely to develop anxiety disorders. So as Muslims, we're lucky that we do not do that, so we're protected in a way, but there are individuals out there that do. And then other anxiety disorders, comorbid with OCD, so somebody with an anxiety disorder is more likely then to get another anxiety disorder. And then we look at depression. Depression being very much comorbid and very common as an anxiety disorder that a depressive disorder co-occurring with an anxiety disorder. And there it's difficult to say which comes first, because somebody who is depressed is then more vulnerable to being anxious. And then people with OCD, obviously, faced with what they are faced with, are more likely to become depressed.
And Sister Fatima, in your experience, have you had patients that had comorbidity or co-occurrence of, let's say, depression and anxiety?
Absolutely. I mean, I agree completely with Dr. Nismira. I think the two they somehow end up coming together. There's a large amount of comorbidity between the anxiety and the depressive symptoms. I think maybe just to add on, there's also specifically with OCD, you do get some of your more medical disorders in terms of the Tourette's, and maybe you can, go a little bit more into that.
I mean, tic disorders, like for example, Tourette syndrome, does have a higher rate of comorbidity with OCD as well.
Can you explain to us exactly what that is?
So it is a disorder, the group of disorders called tics are involuntary movements which occur in individuals. Usually it's more common in males. You will see it quite young. And they have certain repetitive, which look ritualized behaviors, like, for example, certain movements. They are involuntary, so the person cannot control them. They are very repetitive, and they continue to occur. So usually, depending on the severity of the tic or the Tourette's, it can be quite distressing, because in some individuals, it's swearing, for example. So repeating a word that is unacceptable socially, that is derogatory, that is embarrassing to that individual, but then they are not able to control that. So you can see that how it links up with the obsessive compulsive thing, in the sense that it is involuntary, it's irrational, and it's repetitive. And that is the link that you have between them, which is something that they have in common. And for some reason, they do tend to occur together.
Sure, so there's quite a lot that our viewers need to take in, especially if there's comorbidity. But I think the biggest thing that I'm hearing is especially depression that goes hand in hand with much of the anxiety disorders. Once again, we have to take an ad break. Don't go away. Assalamu alaikum wa rahmatullahi wa barakatuh. A warm welcome back to Muslima Insight. Today in Muslima Insight, we are discovering more about OCDs, or also known as obsessive compulsive disorders, and we're also just touching on some of the comorbidity that it can occur with other anxiety disorders. Coming back to this topic is, what are some of the common risk factors pertaining to anxiety disorders in general?
So we looked at gender. So females are twice as likely as males to develop anxiety disorders in general, with the exception of OCD, okay, like we said. Then looking at traumatic events. So traumatic events can trigger anxiety disorders. And then specifically, if we look at acute stress disorder and post-traumatic stress disorder, it is a causative factor. So it is an integral part of the development of those disorders at a specific traumatic event, like we discussed earlier. And then also certain medical conditions are linked with panic disorder specifically. So things like irritable bowel syndrome, with problems with thyroid, so hyperthyroidism is often linked with anxiety disorders as well. And then we even have mitral valve problems, like people with heart problems, which would make sense looking at palpitations and difficulties like that. And then even PMS, so premenstrual syndrome, interesting enough, is also then potentially linked with panic disorder.
Yeah, maybe just to add, I think in the anxiety spectrum in general, is we often find that vulnerability. So in the childhood, if there's a lot of trauma, a lot of instability, these can often lead to not just anxiety, but I think across the board mental illness. You know, that instability at an early age, because infants and children are so vulnerable, and if they're not nurtured and taken care of, if there's a lot of trauma there, that would often result in mental illness.
And I think for in our discussions, off screen, what I've heard you discuss as well is that a lot of the times mental health problems is because of trauma experienced as children.
Absolutely. I mean, like I was saying, I have almost no patients. In fact, I think, I'll say almost zero, but I think there are 0 patients in my practice who have not had any childhood adversity. So if we're looking at mental illness and mental disorder, we stigmatize it, we isolate those people, we want to separate them from ourselves and put them somewhere else. We don't want to take them to the doctor, we don't want to admit it, we don't want our neighbors to know about it because we feel embarrassed. Yet, the same us that are doing that, need to look back and need to look within our home and within our family to look at that individual and see, where did this person come from? What was their childhood like? What adversity did they overcome, or what did they not have enough cognitive or intellectual or emotional reserve to be able to overcome? It's possible that one sibling had resilience and that they could overcome certain adversity, but another one did not, and then they developed the depression and the bipolar mood disorder and potentially the schizophrenia, because it's looking more and more, even with the field of epigenetics now, which is new and it's leading edge, and it's looking at our genes, but not us being a victim of those genes. So our environments influencing which genes are expressed. And I did talk about this before, but it's so exciting for me that I feel that I always need to add it in, that our environments and our childhood and our nurturing, like you said, and the adversity that we experience does mold and shape us. And mental disorder is one of the areas of life that you will see a lot of that. And then going, forward from that, looking at the way things are going nowadays, people are looking at things in a different way. So trying to figure out physical disorders, diabetes, hypertension, heart problems. Why do certain people get those and others not? And there are theories that it all goes back to the mind, and that we are co-creators of these illness. So this is very exciting and very different and off the topic. But it is something that we do need to be aware of and conscious of, that what happens in our home environment and the nurturing and the warmth that is provided for children can have, infinite effects on the outcomes.
And Sister Fatima, from your side?
Absolutely. I did want to add, because we're sort of speaking of stigma, and now we're saying that mental illness is related to childhood adversity and something going wrong in the childhood. And I think, I sort of want to emphasize this quite a bit, that it doesn't mean that it's a completely broken home or absolutely devastating trauma in the childhood. Like Dr. Nazmira spoke earlier of different children having different forms of resilience. Likewise, each individual is individual, and the way we see the world is very different from the next person. So when we speak of that trauma or the vulnerability, it's going to be that child's experience of the environment and their world. It doesn't necessarily mean that it was a dejecting mum or a dejecting environment, but it was the experience of it. And I think that's critical, because if we sort of just say that mental illness comes from, horrible childhood experience, then people tend to feel, did I not bring my children up well? Did I not do it right? And I think we really don't want to create that added on stigma that you're not doing it right, because it's not necessarily somebody's fault. We all are individual and we experience things very differently.
And it could be something that an aunt said or a teacher made a comment, and it's stuck in the mind of that child, causing that child then to start to feel inferior or whatever it might be. And if we come to the other thing that I just wanted to add as well, and it's what Dr. Nazmira was saying, is what I think, like it starts in the mind, causes me to feel a certain way. And those emotions obviously affects the whole body.
Absolutely. And I mean, we're looking at so many illnesses where we have no idea what the cause is biologically and medically, like irritable bowel syndrome, like ulcerative colitis, multiple sclerosis. We have so many of these disorders which, on if you want to interpret it on an energy level, they are created by the energy that is alive and comes from your emotions and from your life experience, and your traumas probably contribute to that. So, trying to look at the individual holistically, you've got to look at their emotional life combined with their physical life. So we tend to compartmentalize and isolate. Okay, the diabetes is physical, and then the depression is psychological, and then there's the psychiatrist and the physician, and it's completely separate. Yet there's links.
Absolutely, because it makes a lot of sense from a coaching perspective. We are also taught what you think makes you feel a certain way, and that is what you start talking about. And the more you talk about it, it becomes your character, it becomes who you are. And obviously, if it's a lot of negative self-thought, self-damage that you do, it's going to affect, and that negative energy is going to store itself somewhere in the body.
Absolutely, and this is how your body then will express it in the form of illnesses. And there's even some theories that cancer develops like this, with repressed emotion, with trauma, and then, if your mind will not speak, then your body will.
The body is going to express that negative energy at some point. What are some of the treatments that you use in your practice when you come across a person that you very well know there was some childhood trauma or something of the like, Sister Fatima?
I think it really varies, in terms of treatment. So there's different modalities to use in different instances. Depending on the severity of the childhood trauma, it would sort of relate to the severity of the mental illness, I find sometimes. And I think your treatment is definitely related. If we look particularly more at your anxiety disorders and your OCD type of things, your treatment methods are going to be more in terms of giving them coping skills, a bit of cognitive restructuring. So we'd look at a treatment method called cognitive behavioral therapy. And this is where you really go into the thoughts. What is going on with this person? What are the, almost what is referred to as, beliefs that are untrue, but quite rigid beliefs, because we often have those. And it's sort of making them less rigid and getting the person to change those beliefs, and it happens over time. But cognitive behavioral therapy is a very directive type of therapy, which can occur over a short-term period.
Absolutely. And what would you say, how powerful or what is the success rate of that?
Well, I mean, in terms of research, your anxiety disorders, your cognitive behavioral therapy is a gold standard in terms of treatment. And I think it definitely is first line. But as I said at the beginning of the show, that, working hand in hand with your doctor is actually quite important, because when you get into these things, so with the cognitive therapy, but other types of therapy, so for OCD we'd use things like in vivo exposure, where you expose them to things that create the anxiety, and then start reducing it. But when you're recreating the anxiety, you're obviously pushing the individual to experience these horrible feelings. And sometimes having medication as a backup to assist during this period is very, very helpful. So I think working hand in hand is actually the best way.
That makes a lot of sense. It is time for us to once again go to an ad break. Stay tuned. Assalamu alaikum wa rahmatullahi wa barakatuh. A warm welcome back to Muslima Inside. Sister Fatima, before the break you were starting to expound for us on the various treatments that is available for specifically OCD sufferers. Can you just continue on your point for us?
Absolutely. Okay, so I spoke a little bit about cognitive behavioral therapy as being one of the treatment modalities. And then I told you a little bit about in vivo exposure. Another treatment modality that you get is called EMDR. This is eye movement desensitization and recognition. So what this is about is often you'd sit with a practitioner and they'd ask you to visualize a bit of what has happened in terms of the trauma, or where the anxiety is invoked. So with an OCD sufferer, it would be to sort of reimagine the compulsion or the thoughts that go into their head, and they'd sort of do a movement with the finger. This is really just a distraction thing, where you'd move your finger and ask the patient to follow the finger. And through that process, as they're reliving the experience of the anxiety-provoking event, you try and recognition the mind. So to remove the anxiety, bring it down a level, normalize, really. And I think that for OCD in particular, though, I find the in vivo would be one of the best treatment methods to go with for the OCD in particular. But like I said before the break, working hand in hand with your doctor is actually quite important. And maybe Dr. Nazmira could just tell us a little bit in terms of the drugs that can be used.
That can go hand in hand with the psychotherapy.
So I agree with Sister Fatima in the sense that we know that for most anxiety disorders, including OCD and PTSD, anxiety disorders respond well to therapy. So cognitive behavioral therapy, EMDR, the exposure and response prevention that she described. And then hand in hand with that, they often find that medication can enable that individual to be able to tolerate the levels of anxiety necessary in order to go through therapy. Because, like I said earlier, in my situation, being a psychiatrist, by the time people get to me, it's difficult for us to not use medicine. It's difficult for us to use herbal medicines because already they've seen other people and they've gotten to the stage where they've now been sent with a problem that needs aggressive attention. So if we look at the treatments that are used for anxiety disorders, in general, there are antidepressant drugs. So a specific class of antidepressants called SSRIs, which are selective serotonin reuptake inhibitors. And this means that these drugs will prevent the serotonin that is available between your neurons in your brain, and it will prevent that from being taken up and destroyed. So it will just allow your brain to have access to higher levels of serotonin, which is the happy chemical. Okay, so that is what makes you feel a little bit better when you are depressed. Now, in an individual that's not depressed, it will not give you a high. So it's not a recreational drug. It is not addictive. It is there to balance out your serotonin in an individual whose levels of serotonin are too low. So this is now looking at it from a neurochemical and neurobiological aspect, because I think it's important for people to know that these drugs are not addictive, and they don't make you high, and they don't make you happy or unnaturally so.
And I think also what I just would like to bring in there is a lot of people are fearful of reaching the door of the psychiatrist because they feel that sense of being disempowered. Now they have to give their life into the hand of taking a tablet. How do you overcome that type of approach that some patients may have?
You know, it must be acknowledged and respected, because it is true. You know, I mean, none of us, I wouldn't want to go to somebody who gives me a grocery list of tablets to take, and then be faced with that on a daily basis, a list and boxes of medicines where I have to look through them and figure it out, and have to like ingest that on a daily basis for the rest of my life. In some cases, this is necessary. Okay, so it's unavoidable if we're looking at risk. So risk of harm to the self, risk of neglect, or risk of harm to other people. In cases like this, we're looking at quality of life. So it's about striking a balance and negotiating and respecting that individual and their wishes, and then working together. So collaborative working is important, and this is how things work now. You know, this is the way of today. In the past, you would go to the doctor, he would write down something, he would give you that prescription, and you would take that, and that would be it. No questions asked, no explanation. So in this day and age, this is not how it works. You know, you discuss things with your patient, you find a balance, you keep them happy to an extent, and then you also treat them in a way that, you know, and help them to understand that you are responsible for them now. So you do have some obligation to maybe at times convince them to take a medicine, you know, if you feel that it's in their best interest, but also try and negotiate so that they are comfortable with it.
Absolutely. It makes a lot of sense also.
Absolutely, yeah. If I could maybe just add, you know, I think you also spoke quite a bit when we broke that it's difficult to take medication, and there's often that stigma attached to it. Do I have to take it for the rest of my life? Is this going to become a chronic thing? And I think really, you know, we need to start looking at illness in general and not just compartmentalizing mental illness is something completely different, because often when you're diabetic or you've got high blood pressure and you need to take those pills for the rest of your life, it's okay. You know, people will pop the pill because it's for their health and well-being. And I think really, you know, that medication is only going to be given to you when you absolutely need it. You know, no one's going to medicate you for nothing. No doctor, like Dr. Nazmira said, there's an ethical responsibility. So when there's an illness and when there's a problem, we need to look at all illness as we're going to treat it with the best treatment method available.
Makes a lot of sense. You must have that combination. And I think also what Dr. Nazmira has said is the combination of not only the medicine, but also the consultation, the talking, giving the patient the information that they need so that they come to that place of realization, this is not disempowering, it is for this period in my life so that I can perhaps move past or beyond this. Moving a little bit further, if you can just perhaps from a psychoanalytical perspective of considering anxiety, what can you tell us about the defense mechanisms that people come up with?
Okay, so if we look at classic psychoanalytic theory, really anxiety was something that an individual would experience. And it's an unconscious anxiety, so it happens internally. It's in the mind, and it's often when there's conflict between sort of the urges, so the wants really, and the availability of acting out those wants in the environment. So for example, if you're a little kid and you're hungry and you want to eat right now, you can cry and scream and you'll get your food. But as an adult, and I'm doing this as a very basic example, but really as an adult, when you're feeling hungry, if you're at work or if you're in the middle of a meeting, you need to suppress that want for a little while to get through your activities, because this is how the world works when we grow up. So this is a very basic example of a build-up of anxiety. And what would happen is we would create defenses in the world to manage these little anxieties. So I'm giving you very simple anxiety, and this is what classic psychoanalytic theory does, is it normalizes anxiety. This is what happens in every single individual. There's a build-up of anxiety, then we defend against it using different defense mechanisms. The mechanisms available, you get your primary defense mechanisms and your secondary defense mechanisms. Just to give you an example of primary defense mechanisms, you're looking at things like denial or splitting. So with denial, if, for example, you've experienced a traumatic event, something has happened and you deny it completely. So there's no acknowledgement that this has happened to you. This is a defense mechanism. Splitting is when we sort of break the world into good and bad. So everything is black and white. There's no grey. And that's also a defense that we use. So it's quite externalized in terms of your primary defense mechanisms. It's not really related much to the self. The environment involves quite a bit of it. Your secondary defense mechanisms are a little bit more mature. So you're looking at things like intellectualization, compartmentalization. So if you go through a trauma again, you'd compartmentalize it. So you'll take it, you'll know it's there, but you'll push it aside because right now is not the right time to work through it or understand it. And I think where pathology comes about is when your defense mechanisms become rigid. So there's an entire repertoire of defense mechanisms, and we can pick on anyone at any point in our life. But when we rigidly stick to one or two defense mechanisms, I think that's where it becomes pathological, and that's where we have problems, and that's where there's a need for psychology and psychiatry.
Dr. Nasmira? Your thoughts on this?
I think that, from a psychological and a psychoanalytic perspective, Sister Fatima knows a lot more than me. But my understanding is similar in the sense that anxiety builds up as we try to suppress our impulses and our needs. And I think the example of the crying child being hungry, a basic and a very primitive need will need to be suppressed and controlled in some way. And that is the root, they say, of where anxiety builds up.
Absolutely. On that note, we have run out of time for today's program. I thank you once again for joining us here today. And from an Islamic perspective, I would like to refer our viewers to chapter 2 of the Holy Quran, verse 38, where Allah Ta'ala says, "And whoever follows my guidance, there shall be no fear on them, nor shall they grieve." And in our discussions today, we unpacked how anxiety is really a fear, an apprehension of what lies in the future. And Allah Ta'ala makes it clear, if we put our trust in His guidance, in other words, following the Quran, following the embodiment of the Quran, which is our Holy Prophet Muhammad Sallallahu Alaihi Wasallam, it will obviously alleviate all these symptoms. And of course, nor shall they grieve. And that clearly refers to us, to a person that is depressed, because with depression there's a deep core sadness. So from our Islamic and spiritual perspective, there is the help, if we can work towards aligning ourselves with the true guidance of what we find in Quran and Sunnah. And then of course also by doing introspection, if we want to also assist in our taking personal responsibility, where we say to ourselves, forgiveness, to seek forgiveness, forgiveness of self, forgiveness of others, and seeking forgiveness from your Creator. Obviously, it lifts the negative energy so that you can open yourself up to positive energy, because now you can put down the past and work towards a positive future with hope and trust in Allah subhanahu wa ta'ala. From myself, Adila, Assalamu alaikum wa rahmatullahi wa barakatuh.